our health systems in Africa, let's just start with Kenya, and our reason for whatever we do with health, is it based on research? Does research inform policy? I mean, how do we get to that point where we say, this is our health system in this country, and this is how it's responding to the needs of the people? Is it based on research or not? Today, it's all about research.
Yeah.
We are joined by the Executive Director of the African Population and Health Research Center, Dr. Catherine Kyobutungi, who will walk us through the work that they do and also the importance of research to inform policy and health outcomes. Dr. good morning.
Good morning. Thanks for having me.
Karibu sana. This is where we, like we've said, we fix the nation, not by having Dr. Catherine from Party A, but from your organization, APHRC. To welcome you to the conversation, Phalaris is going to give you the day's quote, and then let's hear whether that quote speaks to you.
Okay.
Our quote of the day is courtesy of an American physicist. His name was Richard Feynman, and also a Nobel Prize winner. And the quote is, "You don't understand something until you can explain it simply."
Okay. True. I mean, coming from a research background, I think that's something most researchers are guilty of. We assume everybody sees research the way we see it. And sometimes you find it hard to explain concepts to people. And you have to get into that mode of understanding that not everybody is a researcher. So I can totally relate with that quote.
Okay. What does the African Population and Research Center do?
What does the African Population and Health Research Center do? First, we are an African-wide organization that happens to be headquartered here in Nairobi. And we do three things. One is we do research, a lot of research. We call it policy-relevant population and health research. And then we do what we call knowledge translation. And the reason we do knowledge translation is because a lot of research ends up in academic circles and academic spheres and doesn't have application to other people who are not researchers. And so we invest a lot in what we call engagement and translation. And then we do capacity strengthening. And so the reason we do capacity strengthening is because the African continent is one that has the weakest research and development ecosystems, whether it's in terms of people, whether it's in terms of infrastructure, equipment, regulations. So we are trying to fix parts of that ecosystem, building capacity of people, building institutions, and then trying to fix the whole ecosystem that allows research and development to thrive. So those are the three things that we do.
Okay.
As I've said, we're based here, but we work in more than 40 countries on the continent.
That's amazing, and it's a big scope of work, I would say, geographically and from a population perspective. Research and higher education usually go hand in hand. In our case on the continent, how big is the research gap?
How big is the research gap? Gosh, where do you start? Let's start from the...
I even as I asked it, I chuckled because I was just like, I don't know how I expect an answer, but I'm hoping somehow you have one.
I have lots of answers. So where do we start? Let's look at the inputs into the research, then maybe let's look at the outputs and maybe the impact of the research. So starting from the inputs, Africa generally has about 100 PhD holders per 1 million population. The actual number is 98. And globally, the average is about 1,100.
Oh my God.
So we're 10 times less in terms of the density of PhD holders. Now, PhD holders are important because globally, it's the beginning actually of a research career. Like when you finish a PhD, that is like the beginning point. So we have about 98 per 1 million. When it comes to health researchers, now these are people who have both PhD but also non-PhD. We have about 200, and the global average is about 1,200. So these are the inputs into the system. Now let's talk money. How much does Africa invest in research and development? The global average is about 1.7% of GDP. Africa invests about 0.47% of GDP. And Kenya invests about 0.75. So Kenya is one of the good ones. The highest is South Africa, which invests about 0.85% of its GDP. in research and development. The lowest is Mauritania, which invests 0.01% of its GDP in research and development. So you have this disparity across the continent, 0.01 up to 0.85. But the problem is you're investing a low percentage of your GDP based on a low GDP base.
Yeah.
Now, these are inputs. Let's go to the outputs.
Okay.
In terms of scientific production, Africa contributes about 2 to 3% of scientific papers globally. Remember, Africa is about 18% of the population, but we contribute to between 2 and 3% of scientific papers published. So scientific papers are important because they create a body of knowledge, but they also demonstrate credibility and experience to a scientist.
Yes.
And therefore, you use them as a platform on which to, design questions. You're respected. Of course, for personal career growth, you need these papers. So we don't produce enough papers on the continent. Now, if you push it further in terms of patents, Africa produces about 0.1% of patents globally, 0.1% of patents held by nationals. So we've started from, we don't have enough people, we don't have enough money, and therefore, as a result, we don't produce much science.
Wow.
And I think you can safely say that Africans' contribution to science globally can't be ignored totally, and the world
will still spin.
Oh, that's wow.
That's how bad it is.
Okay.
That's jarring.
Now, the reasons. Okay, no, you're going to input, output, impact. Impact is?
Yeah. And
Yes. So the impact, of course, is we've talked about the patents, for instance. If you're and patents are just the beginning. When you have these patents, they are the precursor to some kind of technologies that can be used, whether it is drugs, whether it is diagnostics, whether it is equipment. So if you have a very low patent base and a very low pipeline of innovations that are patentable, then of course what happens is we end up being dependent on the rest of the world for not just our health, but for almost everything, whether it's our technology, whether it's our health, whether it's our roads, almost everything, we end up being dependent on the outside world. And the other problem is that because of the low investment by African governments generally in research and development, most researchers and higher education institutions depend on external funding. So I can tell you for a fact that APHRC, we depend maybe 8% on funding from outside the continent.
Okay.
And that's another story. If you're getting funding from externally, what can you do? How do you set your priorities? What do you research? What is the research for? Who does it benefit? So we end up in a system where a lot of the research that happens on the African continent is externally driven. Some of it benefits us eventually, but some of it does not actually benefit us. So we don't have a lot of research, and then we are not efficient with how we use the research that we produce.
Is Africa the world's petri dish?
Actually, that's a misperception. I've told you, because if you're producing 2 to 3% of papers, that's a very low percentage.
But not from the paper's perspective, from experimental perspective. Yes.
That is also a myth. There was if you look at the vaccines. Let's talk about clinical trials generally.
Yes.
So clinical trials are these studies that help you to test and see, okay, does this technology work? Does this treatment work? Does this vaccine work? Or something like that. And there's a database, if you're going to do a good clinical trial, that you expect that if it's successful, you're going to produce the outcome from this trial. You have to register that trial. And it's some like a quality control mechanism. So there's a database where you can find all these trials done all over the world where they're registered. If you go in that database and look for clinical trials done on the African continent, it's a tiny little fraction, maybe like 2%. So the majority of clinical trials in the world do not happen on the African continent. But there's a perception that Africa, they were the guinea pigs, I don't know where this. It is not correct. And within Africa, they are like the top 10 research and development countries. And if you look at the clinical trial mapping, they'll always be done in those countries. South Africa, Kenya, Nigeria, to some extent Uganda, some extent Ghana, and then of course the North African countries.
Okay.
So most of the clinical trials will be mapped in those countries.
So
There are countries where maybe for like 10 years there's like one clinical trial or none.
I'm actually curious about the perceptions we have as a continent. When we see research come from African research institutes, are we more trusting and choose to adopt something that comes from the continent or that which has come from the West? Because then we deem that to be more credible, that would be a bit more thorough, yet it's not probably based on any kind of study of the people that are living in this continent, but you'll find policymakers being very quick to adapt what has come from the West as opposed to that which has come from the continent.
I think it varies depending on what the issue is, and it's also a reflection of the ecosystem broadly. So if I take an example of a vaccine, so a vaccine is, there are no vaccines being developed on the continent, hardly any.
Yeah.
So a vaccine is developed somewhere, and once it's developed, it depends on what is the disease it's intended to prevent. If it's intended to prevent a disease that's on the African continent but also affects other populations, the vaccine may have been developed there, but then it needs to be tested in a broad range of populations.
Okay.
So that's why you find like some of the clinical trials are happening on the continent, because if it's like a malaria vaccine or a pneumonia vaccine, if you want it to be approved to be used in an African population, then you need Africans or people of African descent in the trial. So if there's no population where the vaccine was developed, then some of the trials will happen on the continent, because ultimately you want to market it to the African population.
Right.
However, there are some vaccines, the basis of the vaccine itself, the biology behind the vaccine, you don't need to test it in every single population unless there are known maybe genetic differences between populations.
Right.
Then it doesn't mean that you must test it in every single population.
Okay.
So what happens before the vaccine is adopted, like in a country like Kenya, there are mechanisms, most of them coordinated by the World Health Organization. They assemble a huge team of experts. They go through the data and the information, the clinical trial, what was the methods, all these things, a huge team of experts. And then they say, yes, we've seen the data and we think that this vaccine will work, and therefore we recommend it for registration or approval. And now the Kenyan government gets a signal from the World Health Organization based on these expert recommendations, and then they adopt it very quickly.
Okay.
Now the challenge is, if you're on the African continent, the fact that we don't have a lot of funding to do good science. We do a lot of science, but when you put it under scrutiny, you find it's very difficult for this expert committee of like 70 people to look at the documentation and then say, yeah, this actually followed the right methodological approach, and it was very rigorous, and the safety, that they are comfortable to approve it.
Okay.
So for you to be an African scientist, to get an innovation that is now being scrutinized by this expert committee, by the World Health Organization, is very, very difficult. And so that's why some of the innovations come, and it's left to our government to say, yes, we approve it, but then it becomes a local innovation, never gets out of the country, and after some time, it disappears off the market, because these innovations are supposed to be bought by big pharmaceutical industries and then manufacture it at scale. But if you didn't have this rigorous science behind it, because you didn't have enough money, then our innovations just die. Yeah.
Just a light bulb just went off. Not even a light bulb, because a light bulb is an idea. It's just when you connect the dots. Is that what's happening with our malaria vaccine?
The malaria vaccine was developed elsewhere. It was tested in Kenya, among other countries. And there are two malaria vaccines. And I think both of them were tested in Kenya. And now, once they were tested, of course, they are found to be efficacious, which means that they do what they are intended to do. But they vary. One has quite a low efficacy around, I think it was around 37%. Another one was high, about 75%. And now, after these tests have been done, now the vaccine is being rolled out. I think the bigger challenge of the vaccine actually is access. There are not enough vaccines in the world, because it's only being manufactured, I think, by the Serum Institute in India, and it cannot push out enough vaccines that can be used by everybody who needs them. So countries are adopting the uptake step by step, maybe starting with high prevalence of areas where there's a lot of malaria. The biggest problem is they're not enough.
Okay. From a farmer perspective, if the vaccine exists, or is this now an issue of patents, and we have to wait for the patent to expire before anyone else in pharma can start producing? Yeah,
it's not a patent issue. So again, vaccines are very, very, very expensive, and because they are very expensive, how they're usually funded through development assistance, if I could call it that, because they are recognized as a public good. Meaning that if you vaccinate 80% or 85% of the population, then the rest is protected. So it is important that a high proportion of people get vaccinated. And if you leave it to the market, you'll never get that protection which protects everybody else eventually. And then, of course, you miss out on the benefits of the vaccine itself. So vaccines typically are funded through mechanisms that subsidize them for populations like ours. Because if we are to spend our little money on vaccines, we may not spend money on anything else.
True.
So that is the thing. Now, the malaria vaccine came out, and it has a certain cost. But for the Serum Institute in India to manufacture these vaccines, it needs to set up like a manufacturing plant for it. And before it invests, there has to be some kind of assurance that someone somewhere is going to put up the money to purchase the billions of vaccine that are required. And nobody so far has put up that money to say that we are going to do that. Now, if you compare to other vaccines, that's why an entity like Gavi exists, because Gavi does sort of advanced commitment to billions of dollars of childhood vaccines. And therefore, it makes it very easy for the vaccines to be manufactured because the farmer know that Gavi is going to buy them. And then now Gavi sort of assures they get like low cost because of the economies of scale, and then now Gavi now distributes these vaccines to countries like Kenya and others. The malaria vaccine, the money for the manufacturing has not been committed to an extent that the manufacturers can go all out.
Makes sense. Okay.
And why is Gavi not committing that much? I mean, why are others not committing that much? Really?
Or even others.
And others.
Yes,
because malaria is known to be a very big killer globally. And the malaria vaccine will actually, of course, then reduce the number of fatalities.
Yes.
You'd expect that everyone can see. So where is the money?
Yes, where's the money? I think it's because money is not infinite. Even Gavi does not have infinite resources. Gavi does not have money on its own. Its money comes from governments like, I don't know, the German government, the UK government, the US government. Okay, the US government has pulled out, which creates a bigger problem. And then entities like the Gates Foundation. So it doesn't have its own money.
It funds Gavi. I was going to say the Gates Foundation works on malaria. Why aren't they?
Yes, the Gates Foundation. The Gates Foundation is a big funder of Gavi. And now, once the money is available, then Gavi says, okay, where do we put it? Because you have to ask yourself, okay, if we do the pneumonia vaccine and the vaccine for diarrhea in children, then do we do malaria or do we do pneumonia? And probably they're going to end up doing pneumonia because pneumonia affects many more children in many more parts of the world. So from a global perspective, maybe it makes more sense to invest in the pneumonia vaccine. So it's still a question of money and prioritization. But the rollout is happening, and I think several countries have started the rollout. So, and I was reading a story from Ghana, I think it was Ghana, where the person who runs the healthcare facility says, we used to have like 40 cases of malaria daily. Now we see like 10 in just a small locality where the vaccine is being rolled out. So,
it's a huge jump.
That is massive.
Huge jump.
Yeah, we could get to zero malaria. Okay, now it's always about the money when you talk about these things. You say that one of your mandates is policy relevant research. How much, and again, these questions, you have the answers, but it's amazing to me that you do. How much of Africa's health policies are actually data informed and actually they're data informed and research informed?
I would say a lot of policies are data informed, but I would say maybe not all of them.
Okay.
And maybe the question is, what is policy? That is that's one question we can ask ourselves.
Yes.
So, because I said earlier, so we have this cycle. We don't invest in research and development. Then we end up getting external resources for research and development. Those external resources are shaped by some kind of evidence that comes out of research. So there's a cycle. You do research.
Yes.
The research says there's a big problem, and this big problem is on everybody's mind, because you're constantly publishing papers, publishing reports.
Yes.
Doing all this. So the global community has a certain understanding of what the biggest problems of Africa are because of the research which is being done. Now, of course, when this research shapes the funding mechanisms are also aligned to these big problems that we keep on talking about.
Yes.
Yeah.
So we end up getting stuck in a cycle.
Yeah.
We research a lot of HIV, TB, malaria. We get a lot of funding for it. So we keep on researching HIV, TB, malaria.
Around the same.
So to a certain extent, HIV, TB, malaria policies are very evidence-informed.
Yes.
Yeah.
So but then the things outside this cycle
Are
maybe
may
not so
be.
much.
Okay.
Maybe not so much.
Okay.
So my personal interest is in non-communicable diseases. Things which are not passed on by bugs, bacteria, or things like that. Things like diabetes, malaria, TB, hypertension, cancer, and all that. Because these things are not visible, they were not visible maybe 15 years ago.
Yes.
Correct.
So they didn't get into this cycle.
Yes, of funding.
And therefore, we have what I would call maybe policy inertia
Yeah.
when it comes to how we deal with non-communicable diseases.
Very true.
So whether it is from prevention perspective, whether it is from the different types of prevention, like how do you shape the environment so that people don't get exposed to things
Yes.
that make them get non-communicable diseases later in life, and once they have them, how do we catch them very early before they become diseases or before they become complications, and then how do we treat? So these are all elements of prevention. So we have a challenge from that perspective. If you look at the numbers, there's something called the global burden of disease, which looks at which diseases are the biggest cause of ill health
Yes.
in different populations, different countries, and then globally. And recent burden of disease studies have shown that actually something like cardiovascular disease, those which affect the heart and the blood vessels, now have overtaken TB, malaria, HIV. So if you look at the ill health caused by cardiovascular diseases in Africa, it's now more than all these three things combined. However, our health system and the money that comes into the health system is still not aligning with this.
It's still focused
Yes,
on
this growth in these new conditions.
Yeah.
Then there's something like mental health or mental disorders.
Yes.
We did a study about maybe 3 or 4 years ago among young people. These are teenagers between. It was on adolescents. I think it was between age 14 and 19. And we found that maybe about 1 in 8 has a mental disorder.
Okay.
Like 1 in 8 was about 12%. Okay, how much are we investing in mental health?
mental health
Or for young people? If you compare it with how much we invest in HIV, TB, malaria, not. So in the end, when I talk about policies, our policies evidence-informed. Those that exist are evidence-informed, but there are those that don't exist because the evidence has not yet percolated into the policy
Into research
making.
and making the policy.
We're stuck in that cycle.
We're starting that cycle.
And all of this is obviously, like you're saying, is informed by the funding, which is not ours.
Correct.
So I want to come back into African academics who also sit in government, who are able to influence government, will always talk in these spaces about the need to fund research by African governments. Some of them work in government. Some of them have actually direct influence in government. So why don't we see an increase in African governments funding research? Where is the gap?
There's a gap. The cake is not that big, and there's just not an infinite way you can slice a cake. So you are in Africa and you have so many issues. You're in Kenya, you need to build roads and all this, and then of course you need politics. So there are several things which are happening. One is that there isn't a very consistent mechanism through which African academics are making the case.
Okay.
There's not like a systematic way in which this is happening.
Okay.
We sit in a conference and we talk about it. We sit in a seminar, we talk about it. Maybe we meet a minister on the street, we talk about it. So
and then the next year you meet at the same
exactly,
conference
and then we talk about it again.
the
So
same
I don't
thing.
think there's a systematic way in which the case is being made. And that's one of the areas where we think actually an intervention should be done or is possible. And you can make the case in ways that politicians understand, because research and development is one thing. There's health, there's education, there's transport, there's housing, there's all these things. And what we fail to do is to make the case inside the whole menu of things that governments need to do. So I can come and make a case and say, if you invest $1 in research and development, the return on investment, we do this a lot, the return on investment is like $11. But I'm talking to somebody who has 40 return on investment analysis on his desk. And so what we need is somebody to say, okay, what are your priorities as government? And then if you fit research in here, this is what's going to happen.
The catalytic event.
Exactly. This is what's going to happen to your health, your job creation, and all these things. So I don't think we're making the case
well
that
enough.
is systematic well enough.
Do you think, Doc, even as we talk about, because I can see the academics speak academic, and they sort of shy away from just engaging into that direct politicking. And then the politician is looking at the electorate and saying, okay, I can hear what the academic is saying, and I completely agree, but how do I sell it to the population?
Yes.
Here, let me just throw this one out there. Do you think it's because of how we are socialized, as Africans? We are not futuristic, are we? We think now.
We just think of.
So research is, if because you're telling me I have so many needs on my plate, and I have only one small cake to divide into these needs. This one is build a hospital today, build a school today, put food on the table today. Research so that then research can inform, today, the day after tomorrow.
We are so
Future, okay, let me deal with now. But this research for tomorrow will come and help sort out all those things. It can help the size of the cake or the dividing of the cake. Is it us? Is it maybe how we just we don't think of future, we think now?
Dare I say we think in election cycles.
Yes.
And even in those election cycles, everything is just short. Even in the election cycle, if somebody came for an election and told you, in 2065, we are going to be, you can't.
It's like trying to tell someone to, save for pension or retirement. People always think it's so far, without realizing that it's going to happen. So I think
this maybe this conversation probably happened 20 years ago, and now it's 20 years later. So it's like tomorrow never comes, and yet there was like yesterday was
tomorrow.
Exactly. So that's what it is, and I don't think it's a mindset. And if it's a mindset, I don't think it's abnormal. I think it's normal. And the thing is how scientists recognize and understand the incentives and motivations of politicians and decision makers, and then align with those, incentives. So instead of making a case of if you invest X number of money, Kenyan shillings, into research and development, maybe you're going to get 5 patents for every, maybe 1 million invest. Instead of saying that, you could also say, you are going to create maybe 10,000 jobs. And this is how you create them. And in addition, that these patents that come out of this investment, maybe 2 of them, potentially could become commercialized. And you could get foreign direct investments, especially from the private sector, to build like a pharmaceutical, biotechnology industry that would create more jobs, and so those things. But many times as scientists, we look at we are going to train another 50 PhD, then we are going to train 200 masters, and then we are going the ranking in our university is going to go a little bit higher. So
I
we
would
need
hope.
to understand politicians
not
and
so-
see the incentives and then align ourselves. with them.
Because
Is
that's
that
not-
so
Far-fetched.
Like
Is it too-
far-fetched?
Is it too far-fetched?
Yeah, to think
Or
that
is it
if
is
you
it too
sold
lofty?
Is it too lofty?
An
Yeah.
ideal? No, it's not, Mariam. The problem
I
is
don't think it is.
the audience. You see, for Dr.
The
Catherine,
audience is scholars
for
as
Dr.
well.
Catherine, it's fine. I mean, that makes a lot of good sense.
Yeah.
Yeah.
Now, the politician does not think about Dr. Catherine as the audience. He's thinking about the electorate.
The
as the
electorate,
audience.
yeah.
Because I'm going to be judged by the electorate who vote for me.
Yeah.
A minority of whom are academics, a majority are not. Now come and start telling me you'll create more PhDs.
How
I'm
does
voting
that
for you
benefit
so that you
me?
create
The
PhDs.
University
Yeah.
of Nairobi will go up in ranking. Wow.
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 And
Cool
yet the
story,
PhDs are
bro.
important. And yet the
Yeah.
PhDs, it's not that the PhDs are not important,
Yeah.
but you can't sell the
But you
PhD.
just
PhD.
and you
can't.
can't just you can't just tell me by create PhD and leave it there. You have got to go very many layers below
Stretch
that.
it.
Because that PhD will land it there, will land it there.
Yeah.
That sounds like a long story. Then somebody else comes and says, I am going to take that money you anasema napeleka university huko ya watu wa university professors wa kule hiyo pesa. I will bring it to this health facility
Yeah.
and we are going to put up a borehole
Yes.
in the health facility.
I'm going to build an expressway with that money.
Exactly.
with
And,
that,
and then of course we end up doing things that are not really advancing or helping the population.
Yeah.
And I just want to give an example of there's a debate about increasing healthcare expenditure. I'm sure you're familiar with this debate.
Yes.
And Kenya spends between 90 and 100 US dollars, which is 12 to 13,000 Kenyan shillings per person per year in terms of healthcare expenditure. But half of this comes from government. 1/3 comes from people, and about 20% comes from other funders, external donors, and things like that. So let's take 6,000 Kenyan shillings as the money the Kenyan government puts into health
Okay.
per person per year. There's a huge debate, especially in light of what happened last year with the US government pulling all this money, USAID, and there's like some kind of anxiety, like how do we raise more money
Yes.
to put into
To bridge the gap.
health? So somebody asked the question, how much money do you think you can mobilize to move from 13,000 shillings per year to even 50,000?
Wow.
Like, just think about it. How much money can you mobilize? Because if you mobilize all the money that was taken away by the US government, you're going to move from like 90 maybe to 100.
Yeah.
From like 12,000 to like 13,000 or 13 to 14. It is very, very difficult to mobilize enough money out there from all sources to reach a point where we can provide all the health services we want to provide. So, what do we use this money for? If you're to break down
This
the health
13K.
budget, the 6,000 shillings that the
6,000
Kenyan government
shillings,
is putting in terms of health expenditure, what do we use it for? Of course, other than healthcare workers, we invest a big portion of it in hospitals, tertiary hospitals. So, does it make sense that we keep on investing our 6,000 shillings in more and more hospitals? And I told you about the non-communicable diseases.
Yes.
I'll just give you some numbers.
Yeah.
In Kenya, if you take adults between the age of 18 and above, about 4% of them have diabetes.
Okay.
So the number is almost 1 million people in Kenya have diabetes.
Diabetes.
And about 700,000 of those people don't even know
Wow.
that they have diabetes. So pull that aside. So people are walking around.
70% of diabetes
70%
patients are not
are
aware.
not aware.
Aware.
They've never been screened. They've never been diagnosed. But if you went into the population and screened everybody, you'll get 1 million.
1 million.
It's just that 700,000 of them have not been diagnosed. Now take the 300,000. If you took those 300,000, about half of them would have been on treatment in the last 1 year. The other half, they know they've been diagnosed, but they're not on treatment in 1 year.
Okay.
The 150,000, if you took them, only about 50,000 would have been on treatment in the last 2 weeks. Now, out of 100 diabetics, if you take 100 diabetes, only one of them has their diabetes controlled.
The rest.
The rest don't know, are not on treatment, on treatment, but they are not consistent.
Way.
So now, if you invest in dialysis for people with diabetes complications, you're dealing with those who should have known 20 years ago, didn't know, now they're on dialysis. Now you have the 700,000 who don't know. Give it 10 years,
They'll all be
dialysis. Queuing up for dialysis.
Correct.
How many dialysis centers can you set up?
Oh.
So,
Wow.
and think, let's go back to this 6,000 Kenyan shillings.
How many even 50,000 would it?
How best would we use that money? So
Exactly.
I can see Dr. Catherine is saying, stop building and buying dialysis machines.
What we need.
Yeah.
Okay, build
So-
them,
Is she saying
build
that?
them for those who are there, but think about the 700,000.
How much should we? Let's now divide the 6,000 then. You know, according to you, how should we spend the 6,000?
So, as I said, there's the 6,000 coming from government, there's
Yes.
6,000 coming from,
Our own contribution and others.
Yes.
Let's first increase the 13,000. Let's start from there. Let's first increase
Okay.
13,000.
Okay.
And I'll first give a number before I go back to how the money should be used for. So the African governments in 2001, they went and signed a declaration in Abuja called
Yep.
Abuja Declaration.
Yep.
And they promised that they would be investing 15% of their annual budget in health. Kenya has been between 4 and 8%. And I don't think there's any African country which has been close to 15%. It's now almost 25 years since they signed it. This year's budget, I've seen estimates that it's about 3.5%. So maybe suppose we say, instead of 3.5, let's keep it at the 8.
Yeah.
8 is not 15, but at least you know,
It is. It's over halfway
Yeah.
there.
it's about halfway. Suppose we keep our government expenditure in health at 8%. Then you increase the 13,000 or the 6,000 that government puts, maybe increase it up to maybe 10,000.
Okay.
So that increase, instead of saying let's keep on doing the same thing we've been doing, maybe let's put that into the
Research.
prevention. No, the prevention.
The prevention.
Yeah.
So it's very, very cheap to screen every adult for diabetes. It's not something that's terribly expensive. Screening, like screen everybody. Once you screen them, pick out those who seem suspicious and then now diagnose them. And once you diagnose them, start them early on treatment. Because treatment for diabetes on average costs about 600 shillings per month. Dialysis costs what? 6,000, I think 7,500 one session.
Per session.
And some people
Per
need
session.
2 per week. So multiply that. So with one dialysis session, you can treat somebody with non-complicated dialysis. You can treat 10 people with non-complicated dialysis for a month.
For a month,
Per
yeah.
month.
So those are the things we need to think about.
Okay.
But this is already what we call, we've advanced in terms of prevention. Let's even go further. Where do people get diabetes from? They're getting it from food. They're getting it from
Lifestyle.
lifestyle and things which are within the power of government to regulate and control. So things like NCDs, if we invest in treating them, I think our systems are going to be overrun in the next decade or so. It's impossible. We talked about diabetes. I didn't talk about high blood pressure.
Yeah.
1/3 of adults above the age of 30 are hypertensive. I have high blood pressure.
Yeah.
And it's the same.
Wow.
Most of them are not even aware. They're walking around with high blood pressure. So we're looking for strokes, looking for kidney failure, looking for all these things. It's impossible to think about the health system that will cater for all this.
Doctor, I'm actually curious. Listening to this, yeah? Are we too far gone? Like, as a continent, are we too far gone to the point where maybe our priorities, if you think about it, Africa's independence in general has not been even a century long across, the continent. So our priorities have been very different from the West. It is, take care of our people, build, develop, blah, blah, blah. And healthcare, I don't know where it ranks there. And hence my question of whether we are far too gone to catch up with the rest of the world, or really put in mitigation measures that then can allow us to deal with these things that you're talking about. Is increasing 6,000 to 50,000. We have other priorities, but from your analysis, is it something that we can be able to actually then take care of to some extent?
Yes, I wouldn't say we're too far gone. If I said that, I'll just go home and stay in bed and not wake up. Yes, I try to be optimistic, and I try to think about things that are within my control, of things that maybe I can shape and influence.
Yeah.
And going back to the question we asked earlier, why are we not making the case? Because, again, if you think about the weak research and development ecosystem, I talked about the people who exist on the continent. What you're trying to do as APHRC is to say, how do you shape we're calling it the African knowledge system, especially in light of what happened last year. The knowledge system is dominated by I think we call it the foreign gaze. Yeah. We produce knowledge for some global thing that we don't think about too much. How do we create a knowledge system where Africans are producing knowledge for African government and African communities and African decision makers, rather than knowledge which goes into publications and never gets back to help us as a continent? For you to do that, you need to invest differently when you think about knowledge production. You need to invest in the researchers producing the knowledge, but also the people who are translating it. Yeah. So we are looking at setting up structures where academics are producing knowledge, but there's a structure that helps translate that knowledge to form what are known as trust relationships with government as knowledge providers and knowledge producers. And once you form those trust relationships, that's when you can start having these conversations. And the production of knowledge is not so much like, we are just producing a paper on this and that. It's like these same questions. How do I combine 50 return on investments to make sense to a minister of planning? Right. These numbers we're talking about, how do we increase? If we increased from 6,000 by government 10,000, how should we apply the 4,000? I'm now talking, but somebody can put this in a model and say, actually the best thing to do is to screen all adults. Or the best thing to do is to fix our food system. Or maybe the best thing to do is to fix our water or air or something like that. Yes. But this is an academic exercise that needs to be done. And this can only happen if you have a knowledge system which is looking at these kinds of questions. Right. Not science or research that is aimed for a global knowledge system that most of the time does not come back to us.
So how do you do that?
How do you do that? Yes, Kenya is actually doing great in this area because, again, working with different people, we've come up with something called the STI Synergy Blueprint. So science, technology, and innovation. Synergy, that's the key word. Blueprint. How do you bring all the stakeholders within the science, technology, and innovation system in Kenya so that they are working together towards a common goal? And working with the Department of State for Science, Technology, and Innovation. This is actually something which could take us to that route. But it takes time and investment in these kinds of system where you have academics producing science, but you have the connection with government. And so with that, now we're talking with funders who are not Kenya funders, but funders to fund science differently. Because I told you earlier, we depend on external funding, and this funding comes in terms of projects. Yes. I write a grant, 3 years, 4 years, I get money, I do the grant, I publish. The grant closes, I get another grant and
move on
to the next one.
Move on to the next one. So if we persuade funders to fund differently and invest in systems where the science is not, I get a grant and I research and I move on. No, I get a grant that allows me to ask the Kenyan government, what is your most important problem? And then now solve it. So the science is to solve problems for Kenya, not to end up in some academic journals. And of course you can publish, but the primary audience is the Kenyan government or Kenyan society. So these are the conversations we're having with some of the funders that don't give us money to run science projects or research projects, give us money to set up structures and institutions that allow scientists to respond to what government wants and then help them setting new priorities, allocating money, and looking into the future and making the case of what to do with the 10,000.
I quite like that. And it's answered a question that had been asked by Eddie Nyabs, asking, is there a harmonized platform that tracks health-related research conducted by Kenyan scholars? and funded by various international organizations. Okay. I think that you've given. And then there's a question on if an individual, that's Bakari Sagna, if a country or individual takes the risks associated with scientific testing, should they be entitled to the benefits of the final product? There's also another question. Someone had made a query. Lenny DeSteve saying we're one of the best investors in research in Africa, ? Then we must be investing wrongly. I just want you to dispel that myth, because I see quite a lot of good research coming out from whether it's Cambridge, so many, especially government institutions and other, players in the industry. But maybe talk to those two things.
Yes. So I think the question of people taking risks to participate in research and then being able to get the benefits, that is actually one of the ethics principles, that the people who participate in the research must benefit. So you must do the research in a population which is going to benefit from it. And so that is really encoded in the ethics approvals of protocols for some of these tests. But then the benefit may not necessarily accrue to the individual who participated. Because if you participate, let's say, in a study on treatment of diabetes, a new treatment of diabetes, and you first maybe participated in the safety profile, you're not diabetic. You're just trying to say that this thing is safe. It does not kill people once it's given. So if you're not diabetic, then of course you won't benefit. If you're a diabetic patient who participated in the trial, usually what is negotiated by governments during the ethics approval is that if this medicine or vaccine or whatever works, then the country will receive a certain number of doses.
For free or?
Yeah, for free. Like if it works, they'll get a certain number of doses of this new technology. So it may not be the people who participated in the trial who benefit, but the country will get like some additional doses. So that happens. Is Kenya investing? If Kenya is one of the good ones who are investing, actually Kenya, if you draw a map of Africa science and where science comes from, Kenya is holding up the continent together with South Africa, Egypt, and those other countries. And as you've said, there's a lot of good science coming out of Kenya. I'll just give, the vaccine trials that we just talked about, the malaria vaccine trial, they happened here, the trials on the pneumonia vaccine, which has really, really been amazing when it comes to reducing child death, death among children under 5. There's the study, the new HIV injection for prevention. Some of that work was done here. So Kenya is really doing great among African countries. I think it's probably like among the top 5 or top 3.
Okay.
It's just that the science may not be visible. But
we are doing something.
You're doing something compared to Mauritania, for instance.
Actually, thank you very much for this. And it's enlightening, and it's good to know that we have people who actually think it's long term. I think as I'm just listening to you, I'm just thinking we need to depoliticize governance. If there's a way we can just find a way of depoliticizing governance. So because everything in government is so political, and our brand of politics, politics is fine, but our brand of politics where it's just it's just too much. Anyway, Dr. Catherine Kyobutungi is the Executive Director at African Population and Health Research Center. We've been talking about that. What do we need to do to finance health research better, for better health outcomes as a continent? Coming up in the next hour is Your World. And today they are discussing something quite interesting. Relationship resume.
Wow.
Are we judging people too much by their past? Body count, baby daddy, baby mama, divorce, drama with the ex. Does history disqualify love?
Swala nyeti hapo. And the ladies in the house are going to be Winnie Lubembe and Mary Mwikali, of course, with a number of guests to balance out this conversation. I'll be tuned in, Juni. Kuna maswali mingi sana.
And of course, on 96.3 Nation FM, it's Claudia Naisabwa and Brian Aseli taking over. Please be sure to listen in. Alafu we cruise nicely into Wednesday to Patani Kesho. For now, enjoy.
And tonight, last word, 9:30.
Tunaongea nini leo?
Leo, tunaongea mambo ya intern teachers.
Wow.
Okay.
Good.
Haya. Tupatane.